I would like to give you the talk about infection in CAR T-cell patients. These are my disclosures. Of course, generally, currently, CAR T-cell therapy, this is standard of treatment of many lymphoid malignancies. However, it is all the time exciting treatment because of very modern technique which is behind this therapy. We know much more about the safety and how to influence survival. However, we do learning all the time. This method is being studied intensively also in patients with solid tumors and non-neoplastic diseases. And from my opinion, the successful therapy is related to treatment of patients regardless of age. However, there are some limitations of this method, just like demanding logistic and first of all, late complication. Of course, currently in US, we have 7 products, but most of CAR-T patients are patients with lymphomas all over the world. This is the main indication for the treatment. And that's why also data concerning infection are based, first of all, on patients treated because of different forms of lymphoma. What about CAR T-cell complication? We can generally divide them into 2 main groups or 3 main groups, short-term and long-term. Some subgroups also distinguish medium-term complication. In this group of short-term complication, we can first of all talk about cytokine release syndrome, neurological complication which are called ICAS, and currently very important hematotoxicity which is called ICAT, and infection, of course, other complication also. In later phase of the treatment after 30 days, usually 28 to 30 days, we can observe also a similar complication, but the most common are infections and ICAT. And that's why I would like to focus first of all on those phenomena. However, from very first beginning, we discussed all over the world, first of all, about CRS, cytokine release syndrome, and neurological complication, because such complications are the most common. Today, with treatment according to recommendation, international recommendation, and first of all with early treatment, we know that we can manage most of such complication, and just like CRS and ICANS, and it was confirmed during last ASH meeting, when it was shown that CRS higher grades and also ICANS higher grades in the perspective on time occurred less frequent than at the very beginning. However, it doesn't concern also prolonged cytopenia and infection. We observe the same rates of such complication, just like, for instance, in 2017. What is very important that if we look at non-relapse mortality after CAR T-cell therapy in patients treated because of lymphoma, we can realize that this non-relapse mortality is about 5% in a perspective of 1 year. But based on analysis presented by French group, we can find that the most common reason for mortality, this is during early period, this is CRS and infection. And after 30 days, this is first of all infection. Of course, this analysis was performed during first and second wave of COVID infection. However, not only COVID infection were related to higher mortality. What we know about risk factors of infection after CAR T-cell therapy? Currently, we know that this is not only number of lines before CAR T-cell therapy, and this is not only underlying malignancies. This is very important history of previous transplantation, history of previous infection, performance status at baseline of patient, baseline hypoglobulinemia, and also older age. But also there are some CAR T-cell related factors, just like dose of CAR T-cell, that the presence of CRS, presence of ICAT, corticosteroid use, and hypogammaglobulinemia also. Current meta-analysis indicates that rate of infection in adults reach about 34%, with severe forms of such infection in about 16–17%, with attributable mortality in about 2%. In patients who are treated with anti-CD19 CAR T-cell, this infection density is highest before the day plus 30 and is caused by bacterial infection. After the day plus 30, we observe, first of all, respiratory viral infection, but viral reactivation, for instance, in comparison to allogenic stem cell transplant setting, are observed not in a high rate. They are rather rare, however, may occur, and it concerns, of course, CMV or VZV. Fungal infections are generally rare and are observed in less than 6% of patients. In those patients who are treated with anti-BCMA CAR T-cell, infection rate is quite high because it reaches about 60%, but density of those infection is highest after the day plus 30, and those infections are caused, first of all, by respiratory viral infection. Viral reactivation as well as fungal infection are rare. Of course, during early period, almost all patients after lymphodepleting therapy are neutropenic, and during this time, early infection are caused, as I mentioned, by bacterial infection, and we observe, first of all, bloodstream infection. Risk factors for such early infection during neutropenia are, first of all, corticosteroids, but also infection just before CAR T-cell. What we know about etiology of more detailed information about etiology concerning CAR T-cell infection. Bacterial infection can be caused by any bacteria, but and of course it is center specific. But of course the most common seems to be infection caused by gram-positive bacteria. Viral infection, as I mentioned, first of all, respiratory viral infection, and not very common fungal. If we compare fungal infection in a setting of anti-CD19 and anti-BCMA, there are some differences. Anti-CD19 is offered to patients with lymphoma, but also acute lymphoblastic leukemia, and that's why in the setting of such patient, we can expect infection, fungal infection caused not only by yeast, but also by molds, and also infection caused by pneumocystis. This pneumocystis is seen as early phenomenon, and as well as yeast infection. In patients after treatment with anti-BCMA products, we observe, first of all, yeast infection, and about 1/3 of patients are presented with Aspergillus, for instance, or other mold infection. Risk factors for fungal infection, this is first of all allotransplant, previous fungal infection, and corticosteroids. Previous allotransplant, first of all, population of acute lymphoblastic leukemia. We were afraid, some years ago, we were afraid about COVID infection in patients after CAR T-cell therapy, and during first and second wave, unfortunately, about 40% of patients with such infection dying. Today, this outcome of patients during SARS-CoV-2 infection is much better, and we can achieve this survival rate in about 85–90% of patients, so it is real improvement. CMV infection, this is area of interest currently according to CAR T-cell therapy. Of course, this is one of the main infectious problem in patients in allo transplant setting. However, we do not know all data. We do not have all data about such complication in CAR T-cell patients, and it for sure requires a prospective analysis. However, there are some groups which present data about CMV reactivation observed in about 30–33% of patients, especially in those who are presented with CRS, who are treated with corticosteroids, who receive immunosuppressants, including anakinra. but clinically important CMV is observed in about 11% of patients, especially those who are treated with corticosteroids, tocilizumab, or received 2 or more immunosuppressants, including anakinra. However, we know that reactivation of CMV in patients after CAR T-cell therapy influence survival, and unfortunately, those patients are presented with poorer outcome. As I mentioned, we have early and late infection. During this early phase, during first 30 days, we observe most of infection, and most of them are caused by bacteria, but also other etiological factors are important. What is the most important during first 30 days? It is to distinguish infection from CRS, because such complication is observed as an early complication. For this, we do not have currently generally approved algorithm, because a number of different cytokines can be observed during infection and sepsis, and also during CRS, cytokine release syndrome. Such analysis, such algorithm should be very easy and simple to perform. For now, we do know that there is a number of different cytokines that can help us to distinguish between those two entities. However, most of them require time to perform and to analyze. I show you on this slide one of such proposals based on interferon level and interleukin beta level. The second proposal was given by Chinese group when they use a very simple analysis based on 3 cytokines added to 2 main, in addition to 2 generally used, just like interleukin-6 and ferritin, and such 3 cytokines. This is interleukin-8, interleukin-1b, and interferon. With this, we can distinguish between infection and CRS. And the last one, which was published a few months ago in 2024, that we can use very simple parameters, just like fever, just like procalcitonin, just like interleukin-6 and CRP, to distinguish between infection and CRS. It is very important that CRS, and especially high grade of CRS, are related to higher risk of infection, and especially bacterial infection, and especially bloodstream infection. The authors of such analysis present also quite simple algorithm, which is based on the presence in blood of interleukin-6, CRP, PCR, and blood culture, and with this we can distinguish between CRS and infection. What about late infection? Late infection may occur at any time after CAR T-cell therapy, but generally are considered as quite mild infection, and only in some situations require hospitalization. Most of such patients are treated as ambulatory patients, and most of such complications are related to respiratory viruses. And those infections are related to 2 main factors: cytopenia and hypogammaglobulinemia. There are different analyses which show that cytopenia, first of all neutropenia, are observed in about 20 to 40% of patients after CAR T-cell therapy, and I'm talking about prolonged neutropenia after 30 days, of course. And if we look at hypogammaglobulinemia, this is also a phenomenon which is seen up to 60% in those who are treated because of lymphoma, and such situation is observed for 1 year or even longer. Patients, now we know that the age is very important in in patients treated treated with CAR T-cell therapy because of the risk of infection in population older than 75. And in this group of patients, we do observe, first of all, late infection. Unfortunately, such infection are quite important because they may influence mortality of patients. So it is maybe not severe, it is not related to severity of such infection, but in this late period, older patients are usually treated by centers which are not very familiar with CAR T-cell therapy and complication with this treatment, and maybe that's why those patients can die. I mentioned also that very important factor related to the risk of late infection, this is neutropenia. Of course, almost all patients during early time after CAR T-cell infusion are presented with neutropenia, and this is effect of lymphodepletion and effect of CAR T-cells. But in some situation, we observed also prolonged neutropenia. And the most dangerous in the context of infection, this is aplastic phenotype of neutropenia, which is observed in some group of patients, not very common, in about less than 20%, 15 to 20%. However, it is a situation when the patient do not respond to growth factors, and neutropenia is responsible for infection. Now we can assess before treatment at the first day of lymphodepletion what kind of patients and who of our patients can develop neutropenia as prolonged complication. We can divide patients according to CAR hematotox score into two main groups, low risk and high risk patients. In high risk patients, the risk of prolonged neutropenia is high, and the risk of infection is also high. Such a score was approved and was validated in lymphoma patients, including diffuse large B-cell lymphoma, mantle cell lymphoma, but also multiple myeloma patients. It was not this score was not approved for ALL patients. However, we are trying to prepare such similar score to help us to predict the response according to neutropenia in this group of patients. Today, we do have a lot of different forms of prophylaxis and treatment of infection, and the most accepted suggestion are prepared by EBMT and EHA recommendation, and shortly I would like to present it to you, because for antibacterial prophylaxis currently there is no routine recommendation to use it as routinely and everyday procedure. But we have to consider this prophylaxis in patients who are older than 65, patients with comorbidities, and patients in poorer general condition. In patients who are after plus 30 days, it should be conditioned with those with prolonged neutropenia or recurrent neutropenia. For those who are presented with neutropenia, there is an algorithm how to deal with this, of course, but we need to start from growth factors. And of course, most of our patients require immunoglobulin replacement given as intravenous or subcutaneous. Prevention strategies, this is also strategy of prevention and treatment, early treatment of CRS with early use of tocilizumab or other cytokine drugs, just like anakinra, for instance. What about antifungal prophylaxis? This prophylaxis is not routinely recommended as well. However, it should be considered in patients who receive CAR T-cell therapy after allogeneic stem cell transplantation, or those with a history of invasive fungal disease. After the day plus 30, it should be considered first of all in patients with prolonged neutropenia, and especially those who are on steroids. And of course, for those with neutropenia, we need to start from GCSF and of course try to explain the reason for this neutropenia. And antiviral prophylaxis is generally routinely recommended, and we advise to use acyclovir or valacyclovir for 1 year after CAR T-cell therapy, or this duration of this prophylaxis can be also based on the number of CD4 lymphocytes. Vaccination is very important, and vaccination should be done for influenza and SARS-CoV-2. However, we know that response to vaccination is lower than in general population. We should start not earlier than 3 months after CAR T-cell therapy. For COVID-19 prevention, not only vaccination, but probably in the time of waves, we can use pre-exposure prophylaxis and early antiviral treatment. There is a number of different problems which should be solved in the future related to CAR T-cell therapy. From my opinion, one of the most important is to distinguish between infection and CAR T-cell toxicities, just like CRS, cytokine release syndrome, and of course to analyze very in details late complication infection and immunological complication which can occur in patients after the treatment. Thank you very much for your attention.